Good morning, Labor, Health, and Social Services Committee. Today is February 28th. I would say the last day of February, but apparently it's one of those years. So, almost the last day. We do have two Senate files before us waiting on some sponsors that may or may not come. But while we're waiting, we'll have Barb call the roll to kick us off.
Representative Clouston. Excused. Representative Hornock.
Here.
Representative O'Hearn.
Here.
Representative Penn excused.
Okay.
Representative Trujillo.
Here.
Representative Ward.
Here.
Vice Chairman Yin.
Here.
Chairman Zwanitzer.
Here.
Thank you.
All right, first up today, we have Senate File 7, Behavioral Health Redesign, Vulnerable Adults. Interim committee bill from us, but I think it was actually brought by the Mental Health and Vulnerable Adult Task Force, who presented to us in our last meeting for our approval as a committee bill. Here joining us this morning is the Department of Health and Mr. Fuchs, who we've asked graciously to present the two-sentence bill to us. They're on page 2 of the bill, you'll see. Senate File 7, floor is yours, Mr. Fuchs.
Thank you, Mr. Chairman. Mr. Chairman, members of the committee, my name is Franz Fuchs. I'm a policy analyst at the Department of Health. Both the bills you have before you this morning relate to the Department of Health's initiative, the Behavioral Health Redesign. And these concern sort of redesigning how the department procures behavioral health services. We spend approximately $100 million a biennium on general funds mostly to these behavioral health centers around the state. Since the past few decades, probably since the 60s, it's been kind of a block grant system. And this behavioral health redesign has been a sort of a 3-year effort to sort of reprioritize what the state pays for and to ensure that the state's getting what the state wants from a policy perspective. So these bills are tweaks. I think it's fair to characterize them as relatively minor changes to this effort. This has been in the works for 3 years. We've been having discussions with stakeholders, with legislators, with the Mental Health Vulnerable Adult Task Force, with Joint Labor for some time now. And I'm happy to answer any questions on the background of behavioral health redesign if you like, or I'm happy to talk about how these bills work specifically. Mr. Chairman, up to the time you have available and your pleasure.
I guess maybe we can just cover this one for now.
Sure.
We'll see if our good Senate co-sponsors arrive in time for the second one to present. But for on Senate File 7, perhaps we could just go over the definition of adults with severe mental illness, including vulnerable adults, and why that's important as a small tweak.
So, Mr. Chairman, members of the committee, you'll note in this bill, what it's doing is it's linking two sections of statute, really is what it does. So it takes Title 35.1, 613 is really where the behavioral health redesign definitions of priority populations live. And what it's doing is it's taking the definition of adults with severe mental illness, so you can see on lines 2 through 9, and it amends it to include a 2-year period in which adults with severe mental illness also includes vulnerable adults as defined in Wyoming Statute 3520, 102A. Now, the important thing to note is that 35.1 is really Department of Health Behavioral Health Redesign statutes. Title 3520 is Department of Family Services, Adult Protective Services. So they're two different, they're in the same title, but they're two different sections of statute that don't relate to each other. And so this basically subsumes the definition of, basically presumes that adults with severe mental illness are also vulnerable adults. So if you were to go to 3520, the definition of a vulnerable adult in Romanet 2018 is a vulnerable adult means any person 18 years of age or older who is unable to manage and take care of himself and his money, assets, or property without assistance as a result of advanced age or physical or mental disability. Advanced age is further defined as over 60. So I guess that gives you an indication of when this statute was written. But the important thing is here, so that definition itself does not inherently imply a mental illness or behavioral health issue. There could be a physical disability, it could just be advanced age. Dementia is not considered a mental illness. They're physical brain diseases that are different from mental illness. So these folks would not automatically be included in the tiers, the priority population tiers, even if the functional result of being unable to manage their lives and need assistance with managing their lives is the same as people with severe mental illness. So this bill essentially just in some ways, many of these people would qualify under these priority population tiers because they likely also have a behavioral health concern, but it's sort of a belt and suspenders to ensure that the vulnerabilities are considered in this population. So with that, Mr. Chairman, happy to stop and take any questions.
And the reason it's 2-year time limited, again?
Mr. Chairman, this committee chose to include a variety of sunsets in these two bills. So both this bill and the second bill you'll consider have 2026 sunsets.
And that's really because the program initiates after 3 years of work this summer. And so to make sure it's operating like we want it to operate, we're just kind of keeping status quo for a couple of years and making sure it works before we tweak with it even more.
Mr. Chairman, that's
fair
accurate. We're
assessment?
going to have a variety of reports that we'll submit to this committee for your consideration on how it's going. There are a lot of unknowns because we are transitioning from one system to a completely different system. So there's a lot of things we don't know that we'll find out after July. And I think that's the intent of these reporting requirements and sunsets, is to ensure that it's going as the legislature intends.
Those of you on labor health next term, if you run for again and get on this committee, it'll be a whole lot of behavioral health redesign for those 2 years, I'm sure. Other questions? Representative Ward.
Thank you, Mr. Chairman. By how many people would this expand the definition adults with severe mental illness to include?
Mr. Fuchs, if you know.
Mr. Chairman, Representative Ward, that's a good question. And there's kind of a broader point for these two bills on who is eligible for services. So if you indulge the digression a little bit, there's essentially the world of before BHR, right? This is the block grant world where we have been doing this for decades, right? And under that world, pretty much anybody who could go to these mental health centers and there'd be a sliding fee scale based on their income. So pretty much the universe of eligible people was fairly large. Under behavioral health redesign, so without this bill passing, right, or its companion bill passing, behavioral health redesign shrinks eligibility significantly to just the priority populations, right? So generally speaking, anyone over 200% of FPL, if they have minor behavioral health concerns, will not be eligible for state funding, basically, is what happens. These two bills tweak that eligibility a little bit to expand it a bit on the margin. So it goes from kind of wide to relatively small if these bills don't pass, to kind of a little bit in the middle, but more on the side of the behavioral health redesign. That's kind of where it goes. Now, as to exact numbers, I'm afraid I'm going to have to call my Lifeline Director Schmidt to see if she might have a rough idea of how many vulnerable adults they serve in adult protective services. But it's hard to know how many of them would have qualified under the existing priority populations if this bill didn't pass, if that makes sense. So that's kind of the problem, is we've never categorized people with eligibility. We've never actually assessed them in that way before. So it's very hard to give you a number of how many people would fit under these sort of overlapping circles.
Which is why the 2-year window, so we can get all that data and then decide how to move the program.
Mr. Chairman, that's correct.
And I'm sure when Ms. Schmidt comes up, we'll hear her if she has that information. Representative Trujillo, question?
Thank you, Mr. Chair. In the tracking through this program, is there a tracking mechanism we have a lot of homeless people out there with mental illness. Would you guys be tracking if they are able to get the help and then get in the workplace? Are you tracking if they get jobs after this process?
Mr. Fuchs?
Mr. Chairman, Representative Trujillo, we are piloting a relatively small program for 900 slots. So we're carving out $5 million out of a $50 million bucket. And we are going to set up a program that really tracks outcomes for a handful of clients, so 900 people in this system. And there are up to potentially 20,000 people that are currently served. So it's not everybody. And those people are sort of the tippy top of the pyramid. These are people coming out of the state hospital, people coming out of the state pen that are really high risk of recidivism, kids with high needs coming out of DFS. So being homeless is not specifically a focus for those slots, but many of them would likely be homeless, coming out of the state hospital, being discharged without any supports to the community, for example, or without someone looking after them and caring about their welfare. Potentially, they would be at high risk for being homeless. So what this outcome program will do is it will reward the centers who take on these clients, and if these people are engaged in their community, if they're employed, if they're housed, if they are compliant with their treatment and in progressing with their treatment, they will be rewarded, the center will be rewarded every month for achieving those outcomes on behalf of the client. So that is a part of the behavioral health redesign that will achieve kind of a little bit what you're talking about, but it's not necessarily focused at all the entire homeless population. If that helps answer your question.
Other questions right now for the Department of Health? Representative Yin.
Mr. Chairman, thank you. So, Mr. Fuchs, I appreciate you being here. Can you give us just a little bit of context on the history of this? Because I know many members here weren't on labor and health or in the legislature during that time. I think it was 2021 when we passed the behavioral health redesign, where we moved from this block grant model where we gave block grants to communities and they had to cover a broad range of services and a broad population base. And so can you talk about how we narrowed those to these priority populations and that this bill is in essence trying to deal with some of the effects of that big redesign where we're trying to adjust the program as we implement it?
In 4 minutes or less. Good luck.
Mr. Chairman, Representative Yin, so I think at the end of the day, what is the problem we're trying to solve with BHR is kind of the root answer there. And the problem we've seen for the past decade is that the community mental health centers have a really extremely broad mission, right? They've been tasked to serve anybody who walks in the door, and we give them state funds for that. As a consequence, the really high cost and really high needs people that are coming out of the state hospital, coming out of the state pen, there was that whole justice reinvestment project we did a couple years ago. The idea is if we can try to target the state dollars towards those really high needs folks that are coming out of institutional settings, we might be able to avoid them going back and sort of going back, reoffending, going back to jail, going back to prison, or going back to the state hospital. If we can provide the supports in the community and refocus the mission of the community mental health center, neck it down to those priority populations, that will serve the state's interest because we currently have this sort of bleeding hole. Title 25, for example, we spend as a Department of Health $14 million a biennium on overages because the state hospital is full. So the idea is if we can reduce the crowding and also Department of Corrections sends people, prisoners to Missouri or Mississippi, right, at a marginal cost. So the idea is to help the state, selfishly from a state perspective, right, is we want to solve some of these problems we're seeing on the institutional side by incentivizing our community providers to really take care of these folks coming out of these institutional settings. So that was kind of the problem we were looking to solve with this redesign. Now, of course, when you prioritize people, by definition, certain people now are not priorities. And so there are, of course, consequences, right, for some people that may lose access to care because they no longer fall into those groupings. However, the landscape of behavioral health has changed significantly since the 60s. I mean, private insurance, there are far more providers since that time, since the block grant model was built, right? Their insurance coverage is much more generous. So there's reason to believe that a lot of the people that may have been served by the block grant model before can now be served through other payers and other mechanisms.
Other questions for the Department of Health? Representative Hornock.
I've got a couple questions. The first is in the definition of vulnerable adults. Can you explain how that's not grandma with dementia, where she's at our house, we're taking care of her kind of thing? It seems like that is who falls into this definition. How is it not? Because you said it wasn't.
Mr. Chairman, Representative Hornock, I'm afraid I'm not familiar. These are the DFS, APS statutes. So I'd have to refer to my lifeline as far as how DFS interprets this definition. I'm fairly confident it's not everybody's grandma with dementia. It's a fairly neck down prioritized population for DFS as well, but as far as how they interpret this statute literally and implement it in reality, I can't speak to that. Sorry.
Yeah, I appreciate that. I do have a follow-up on something you said. You talked about rewarding, and I think community centers. So what centers are we talking about specifically? And then what's the reward you're talking about?
So, Mr. Chairman, Representative Hornock, the centers are going to be your behavioral health centers around the state. So it's the WAMSAC organization. So there are 14 community mental health centers or substance abuse centers that have historically been as part of this network since the 60s. And those are the providers that are involved with behavioral health redesign. And they are the historic recipients of these block grants. So it's not every behavioral health provider in the state. It's just that network of 14 centers. The reward itself is we are taking $5 million of the 50, and we are going to be assigning a per member per month. So the average will be $450, which is essentially tied to clients for that month. So if I come out of the state hospital and I come back to Cheyenne and I'm assigned to VOA, Volunteers of America, which is the BHC here, then for every month that I have high outcomes, say I go back to my job, I'm functional in society, I'm compliant with my treatment, VOA will get paid a certain amount of that per member per month, depending on how well I'm doing. And if I don't do well, if I'm homeless, if I'm not employed, et cetera, they will not get paid. So we are tying the money directly at risk for achieving those outcomes on behalf of clients. Mr. Chairman, Representative Hornock, did they answer your question?
Which leads me to a couple more questions. Are these centers, are they state-run, are they privately run, or a mix of both? And then the $5 million incentive, is that something new within the health department budget? Is that within the health department budget? Where does that $5 million come from?
Mr. Chairman, Representative Hornock, to answer your first question, these are all nonprofits. So these are, sometimes they're county-owned, or county-run, but I think the vast majority are nonprofit organizations with boards. And to your second question, this comes out of Hyde. So we have that $50 million a year ballpark figure. We're taking $5 million of that. And it's part of a broader redesign where, the block grants go to a certain amount pays for services, and then we're reserving a certain amount for these outcomes. So there's no new money really flowing into the system. It's just redesigning how the existing money is being paid out.
And I know in the interim, you did bring some charts and the numbers and certain examples for certain people on what level of acuity they'd be at and how the system would work. And so we could certainly provide that for the committee if anybody, I think it's in our meeting materials actually, from interim meetings as well, on a very lengthy presentation on behavioral health redesign. Other questions to the Department of Health? Seeing none at this time, thank you. DFS, since you were referenced, we'll bring you up next. Yeah. And thanks for staying with us, Department of Health. Go ahead. Ms. Schmidt, welcome.
Good morning, Mr. Chairman, members of the committee. My name is Corin Schmidt. I'm the Director of the Wyoming Department of Family Services. And you had a question, I think, first about what is the population of adults in our adult protective services. And at any given time, we average about 168 cases of vulnerable adults case management. Our current data collection system doesn't necessarily collect the diagnosis or the reason. It happens through narrative, but it's very difficult to tease out. But just from anecdotal, we think about a quarter or so of that population has mental health issues. The question about the definition of vulnerable adult in regard to dementia or Alzheimer's, I think that was the testimony that Mr. Fuchs provided, that it's not necessarily a mental health issue, but certainly we would look at competency as an issue for protective services, for adult protective services. So we may work with a person, the grandmother who does have dementia or Alzheimer's, and try our best to connect them with services or family.
And then any other comments in general on the legislation, if you have some?
Mr. Chairman, I think it's important for me to explain how it is that we access behavioral health services as a system. And this involves both our children, our families, and our vulnerable adults. Our main goal is to keep people safe at home. And the way that we approach that then is through a lot of case management. And in this case management, especially as we're starting to identify maybe an adult who is not vulnerable, but yet without some sort of level of service, could then potentially become at higher risk of self-neglect or vulnerability in another way. What this program does, what this statute does, is it signals to the behavioral health centers that when we make a referral because of a vulnerable adult, that's an important referral and that they place them in a priority order. One of the only ways that we access behavioral health services if a person is not on Medicaid is through this behavioral health center system. So for example, if we have a vulnerable adult that's not yet 65, that isn't on Medicaid, but yet is at risk of having to leave his or her home because of maybe a mental health issue, we want to signal to the behavioral health centers that it's important that they prioritize this person so that person can get the needed services and be able to hopefully stay home.
And in general, 2 years of data after this program commences, we can refine and decide a better definition or a better categorization in the future. No concerns there. Other questions for the Department of Family Services? Seeing none. Thank you much. AARP or WAMSAC, or you can. Welcome, Ms. Somerville. Floor is yours.
Good morning, Mr. Chairman, members of the committee. Andy Somerville, Executive Director for the Wyoming Association of Mental Health and Substance Abuse Centers. And we stand in support of this bill as part of the behavioral health redesign process. All of the community mental health centers have been working incredibly hard alongside the Department of Health, Department of Family Services, and the Department of Corrections over the last few years to try to get this ready to go. And as was stated, our go date is July 1 of 2024. I'd like to address just a couple of the conversations so far. From a statute perspective, what this bill really does is signal to us that these clients are a priority and that they should be considered as such in Tier 1. If the statute is not passed, we will still serve these adults if they fall within one of the other tiers. So Tier 2 is indigent with high needs, so that would be below 200% of the federal poverty level with a significant mental health diagnosis. Or Tier 3 is just general access, but you have to be below 200% of the poverty level. So that's how we would handle that. If the statute does not pass, is we would just look to see if they qualify in the other tiers. If they don't, we would not be able to provide services to them under the new behavioral health redesign program.
So can you tell me kind of what that means? When you say we can't provide services, you just say, go away? Or you refer, or what would that look like?
Mr. Chairman, thank you for that clarification, our opportunity for clarification. So we would not be able to provide services under the state contract. So the first thing we would do is look to see if there are any other avenues. Can we help them get an insurance plan? Can we, do they want to be a self-pay client and just pay the bill? Or does the family want to take care of that potentially? And then secondarily, we would, if we couldn't serve them at the center, then we would look to refer them out to other sources. But what I would tell the committee is that the Community Mental Health Center is really, the system in the state is the safety net. We are the place where folks go that really don't have any other options or a lot of other options to receive mental health and substance use services. So although we would certainly try our best, that would potentially present a difficult situation. And that is something that we've been working through with the behavioral health redesign project as described by the Department of Health, is we are necking down the population that will be eligible for services.
So if you're the last resort, where do you refer them to? I guess the emergency room, or say, get some sleep and good luck?
Mr. Chairman, I think the very last option would be to look to our philanthropic partners for charity care. We do work with a lot of philanthropic organizations. The centers work on a variety of different grants, and so our hope at the end of the day is that we will be able to help those people that end up in that situation in that way. But as we're going into the first year, we don't quite know what that's going to look like in terms of the numbers. It was very accurately stated that we just don't have a lot of very good data specifically on people's circumstances, insurance coverage, that type of stuff, moving from the block grant system into this new system. One of the things we are excited about behavioral health redesign is the ability to provide better data, both for the centers and for the state, so we can really get a good idea of what the clients coming in our door in an aggregate, what their needs are, what that looks like.
Sorry to interrupt, keep going.
Mr. Chairman, Representative Trujillo, you had asked a question regarding the homeless population. And so in addition to the 900 clients that we're going to be working with for these slots for this first year to really intensely track those outcomes, all of the community mental health centers are making massive changes to their electronic health records in preparation for behavioral health redesign. And one of those goals is to try to be able to be even beyond the 900 at the community mental health center level, better track people's circumstances, employment, housing, all of those pieces, so that we'll be in a position to provide better data. So we do hope to be able to better broadly answer that question after the first year of what that looks like, even for the entire population beyond the 900. And then Representative Hornock, you had asked a question about dementia, and I just want to confirm, while somebody with dementia can have a co-occurring mental health disorder, we cannot consider dementia as a primary mental health disorder diagnosis. So it is possible that people have co-occurring disorders, and that does happen, but it's not the entire population. And then also, Representative Hornock, you had asked about the centers. So there are 10 community mental health centers across the state now. There's been a lot of change in that system over the last couple of years. And those centers are, all of them are there's one county-run entity, there is one hospital district-run entity, and the rest of them are private. Mr. Chairman, we stand in support of this change of piloting it for 2 years and seeing what that looks like and bringing those reports back to the committee. And with that, I'd stand for any questions.
Okay. Generally in favor of the bill?
Mr. Chairman, we are.
Okay. Questions, Representative Penn?
Thank you, Mr. Chairman. Could you just tell us what numbers we're talking about when we say at or below 200% of the federal poverty level? What does that mean?
Go ahead, Ms. Lombardo.
Mr. Chairman, Representative Penn, so I apologize. I did not bring my FPL chart here with me. I'm not even going to guess, but if you give me a second, I'll bring that information back for the second bill and I'll pull that up. In terms of actual numbers of clients, that's data we don't have. We know that these people are coming in and a large, well, probably not a large, about half of them are probably under that poverty level, just based on our anecdotal kind of data that we have right now at the community mental health centers. But after the first year, we should be able to bring back a much more specific answer.
Representative Hornock.
Chairman, the homeless people would already fall under a definition of indigent adult. Is that correct? So they would already be covered under the severe mental health stuff that we're talking about, right?
Mr. Chairman, Representative Hornock, presumptively, yes. The definition of indigent in that statute actually refers to the financial capability, so it's less than 200%. So we would assume so, that they would not come with those resources.
Okay, other questions for mental health centers? Seeing none. Thank you.
Thank you.
Lindsay, Bruce, Tom? We're on a first name basis in Labor, Health, Social Services. Mr. Laycock, welcome. Floor is yours.
Thank you, Mr. Chairman, Committee. Tom Laycock with AARP Wyoming. We're a membership organization for people age 50 and over in the state of Wyoming. This bill did ultimately come out of debate and conversation in the Mental Health and Vulnerable Adult Task Force. We followed that task force all summer long from the standpoint of the consumer, sort of that consumer protection. If there was any concern that some of these proposals were going too far, we looked at it as our job to push back a little bit. This particular bill in front of you, I think is fairly simple, straightforward. We're very supportive of it. We appreciate kind of what the task force did. We hope it gets another shot next summer as well. But we appreciate what it's trying to do, not to mention the ability to hopefully get people those services that they need just to stay in the home, because we know when people do matriculate into nursing home care, that cost comes at about $5,000 per person per month. So spend on this could be a bit of a state savings if done correctly. With that, I stand for any questions.
Questions for ARP? Representative Hornock.
Thank you. Would you agree or disagree that the definition of vulnerable adult, which we're now imposing into the somebody with a mental health illness, would cover somebody who is elderly and they get taken by somebody who calls them up and says, hey, I need money. They write a bad check. They can't really handle their finances much anymore. They're just getting to that age where they're susceptible to fraud and that kind of thing. Would you say that this definition covers those kind of people?
Mr. Chairman, Representative Hornock, the definition of vulnerable adult actually came up for about 2 to 3 meetings. And that question of whether or not that particular definition needed tweaked, whether it needed completely redesigned. LSO did a dynamite job of figuring out what all 50 states, how they define vulnerable adult, put it together. Ultimately, between our friends at the district and county attorneys, as well as law enforcement, the conclusion was reached that a change to that definition was not needed. So that was an interesting conversation. Now, in terms of age alone being an indicator for fraud and being susceptible to scammers, interestingly enough, I think it's 41% of those who reported being scammed last year to the Federal Trade Commission were actually 30 and under, age 30 and under. So it does happen at most any age.
Other questions? Seeing none.
Thank you.
Thank you much. Anyone else here to testify in the bill? Okay, seeing none and no one online, correct? No one jumped in on the last half an hour? All right, committee, we'll close public comment on Senate File 7. What's your pleasure?
Move the bill.
Moved by Chadwick, seconded by Yin. Questions or discussion? Again, it's a 2-year definition change to catch this population for the behavioral health redesign to make sure we don't miss on anyone. Is this an amendment for this bill? It is.
Yep.
Okay, amendment being passed down.
Yeah, I've got one.
I'm just,
There should be enough for
There should be enough.
size, too. Can we give it a toss in case?
with that, I guess I'm going to ask for any amendments. Representative Penn.
Thank you, Mr. Chairman. I would like to bring an amendment. My concern that I've had, and we've kind of discussed a little today, but people have come to me and with the concern that the definition could be used. I mean, we've heard testimony today that it shouldn't. We don't think that it will translate in a potentially negative way, but I mean, what was said is that this definition assumes that adults with severe mental illness are also vulnerable adults. But there really, I don't think, to my comfort level, is something that prevents us from going the opposite direction and saying that the assumption that vulnerable adults also have severe mental illness. And so this, I think, just clarifies that we're not doing that.
Exactly what Tom just said, right? Not all people get old.
Shall not solely establish presumption of severe mental illness. So, and did you move the amendment then?
I move this amendment, yes.
Is there a second? Seconded by Ward. And we heard some explanation. Any discussion, committee? Representative Chadwick.
Thank you, Mr. Chairman. So from our health department people and family services, do you see any problems with doing this?
They just now got it, so we're going to pass it around. I do have a question while they're thinking about that, Representative Penn. So this sentence looks like it would go in before the June 30, 2026 kind of 2-year window. So this would be permanently added to the adults with severe mental illness definition. I'm just making sure that was your intent.
Mr. Chairman, thank you. I do think so. It says for the purpose of this paragraph, and this is the paragraph that we're amending to make that association, and so I believe so. But if there's further discussion, I'm open.
Okay. I don't know, department, if you had a chance to read over and think about it on the fly. But if you see any concerns with this language.
Mr. Chairman, we don't have any concerns with that language.
Okay. All right, further discussion from the committee. Seeing none, and question being called. All those in favor of the amendment, say aye. Aye. Opposed, say no. That amendment has passed. Any other discussion or amendments on the bill? Representative Hornock.
Though the amendment helps ease some of my concern, I still do have a couple of concerns with passing this, and that is, we are really expanding the definition of those with severe mental illness to include vulnerable adults, and you know, that could create quite a strain on families that are dealing with aging parents or something like that, that now our department kind of almost forces the hand sometimes if they have certain qualifications. And then the fact that was mentioned that if we do nothing with this bill, most of these people will still be covered because they do meet additional criteria somewhere that whether it's income level, whether it's other mental health things. I'm a little worried by expanding the definition here that we're going to infringe on some things happening within families. You know, my family's in that situation right now with some things. So, you know, I would just be fairly careful. And this little 2-sentence, though the idea is, you know, good, we want to help those people. This little 2-sentence bill is a $5 million price tag. So kind of interesting in that respect. And I just really can't support that right now at this time. Thanks.
Okay. Other discussion, Representative Yin.
Mr. Chairman, thank you. As of right now, February 28th, 2024, the behavioral health redesign is not in effect. It doesn't go into effect until July 1st, 2024. So the community mental health centers are addressing this population right now. It doesn't expand the population they address. It only changes the definition of what will go into effect July 1st, 2024 for the 2 years between 24 and 26. We're not adding new people. We're just keeping some people into the existing definition of people that are covered right now.
Once again, I've got to go to the health department people. My understanding from what your testimony was is that this would utilize $5 million within your $50 million block grant. Is that correct? So there's no new financial obligation. There's no true financial impact to general fund, et cetera.
Go ahead.
Mr. Chairman, Representative Chadwick, so the discussion on $5 million was related to the outcomes pilot, which is really not part of this bill. It's part of the broader behavioral health redesign. So we're taking $50 million and reconfiguring it how we spend it. And of that, we're diverting $5 million to this outcomes pilot. So the answer is there is no general fund impact to this. But the $5 million is not as relevant to this particular bill. It's a separate program that we're doing as part of this broader behavioral health redesign.
Okay. Further questions, discussion? Seeing none and question being called. Barbara, if you would call the roll on Senate File 7.
Representative Chadwick. Aye. Representative Clouston.
We'll leave it open for him if he shows up
Okay.
before 10 o'clock.
Representative Hornock.
No.
Representative O'Hearn.
Aye.
Representative Penn.
No.
Representative Trujillo.
Aye.
Representative Ward.
No.
Representative Yin.
Aye.
Chairman Swanitzer. 5 aye, 3 no, 1 on hold.
One on hold. All right, committee, with that, I'm just guessing I'll cover both of these, assuming the other one passes and take this one on the floor. I haven't taken one. Actually, yeah, you're right. Vice Chairman Larson might take it as well because he's been kind of the instrumental person behind this whole thing for 3 years. With that, we're on to Senate File 115. Not seeing our good Senate colleagues join us. But committee, let's present Senate File 115. Similar to all the explanation we heard on the other Senate File 7 before us, this is another, I don't know, we'll call it a tweak to make sure the redesign works as intended. We talked about this 200% of federal poverty level. And so for the window, again, from 2024 to 2026, we will continue kind of the status quo for the past 50 years, but then reassess before July 1st, 2026, what becomes indigent and what the state covers and what the state pays for. With that, Mr. Fuchs, I don't know if you have any, Department of Health has any thoughts or concerns on Senate File 115, or we can ask questions to you. Department have any thoughts initially?
Mr. Chairman, members of the committee, again, my name is Franz Fuchs. I'm Policy Analyst, Department of Health. There's two major parts to this bill. The first part is very similar to the past bill in the sense that this is lines 3 through 13 on section 1, page 2. This takes the definition of indigent general access clients, and it lines out the requirement to be uninsured for a 2-year window. So previously, if this bill doesn't pass, again, we have those kind of three worlds. We have the world of today where BHR doesn't exist. Pretty much anybody can walk in the door and be served on a sliding fee scale. If BHR goes into effect July 1st, and if this bill didn't pass, we would exclude people from this particular priority group who have insurance. If they are under 200% and have a insurance plan that covers behavioral health services, they would not be eligible under this particular section. Now, if their needs are high enough, they may, of course, fall into a higher category. So there may be people with insurance that have severe mental illness or acute mental illness and so on, in those higher tiers. But for this particular category of indigent general access clients, BHR, as written today, requires them to be uninsured. What this does is it takes away that requirement for 2 years. So it adds if a person who has private or public health insurance shall not, it repeals that one little sentence and then adds it back as with a sunset, if that makes sense. So the red addition puts the language back after July 2026. And the reason for this is there are certain cases where certain insurance benefits aren't covered typically. So for example, Medicaid, imagine someone on Medicaid. Medicaid does not cover residential substance use disorder treatment. We don't pay for room and board. So historically, that person could have gone to these behavioral health centers if they needed that treatment and gotten it. After July 1st, if this bill doesn't pass, if that person doesn't qualify in any of the higher categories, we will no longer pay for that benefit. So that person will not receive that substance use residential treatment. Now, it's a limited set of benefits. It's not all behavioral health that they will be excluded from. It's just the ones that Medicaid doesn't cover. And similarly, on the private insurance side, there are certain benefits that aren't covered by private insurance, or have significant limits. So that's the main concern or problem that this tweak is trying to address, is looking at the cases where someone may benefit from those services, but they just happen to have insurance, which is, we want people to be insured. We don't want an incentive put in place to not screen people or not get people coverage because they want these other services, if that makes sense. So that's the primary reason for that first paragraph. The second, section 2, is different. This doesn't deal with eligibility. This deals with what we call third-party liability. So typically, just to take Medicaid as an example, Medicaid receives a claim from a provider. We have database connections with, say, Blue Cross Blue Shield, and we find out that person actually has a Blue Cross plan. Medicaid will deny that claim and say, go bill Blue Cross. They have insurance coverage that pays for this benefit. Medicaid's the payer's last resort. We're not going to pay for this. That's what happens now, and that's what will happen after July with behavioral health redesign, with these state funds, not just Medicaid. With the state funds, we will identify if that person has insurance, and if they do, we will deny that claim and tell the provider to bill insurance. What Section 2 does is it basically gives us a year to not necessarily deny those claims, but keep paying the claims as we do today, because in essence, we don't do third-party liability processing right now. So it kind of keeps the status quo going for another year while we collect information on, how much third-party liability is there. We don't know. We really don't know what what amount we could potentially save by denying these claims. And there are a whole host of options, to deal with third-party liability beyond denying claims. Like we can pay the claim and then bill the insurance company later to recover. There's a host of different options we could implement. But we don't have the information to give you a recommendation on what the best way to do it is. So that's what this section does. It gives us a year to kind of study the issue, collect information on third-party liability while keeping the status quo going for a year. And then we'll report back in 2025, September, on a recommendation for designing a new third-party liability system. And I think the main,
That's just because we don't have the data when this kicks off, and so that'll give us a year to collect all the data and then make some rational decisions based on the numbers and the populations we're seeing.
Mr. Chairman, that's correct. And I think there's like some corner cases. So for example, imagine somebody with employer-sponsored insurance. They have a $5,000 deductible. They end up involuntarily hospitalized. And they go to the state hospital. And then we discharge them from the state hospital. They still have that employer plan, and they want to get treatment at this community mental health center. So even though they fall under a very high priority population, we would see that they have that $5,000 deductible, and we'd say, okay, we're going to deny this claim, go bill insurance. Well, of course, the insurance company, they have a contract that they bill the person because they have to meet their deductible. Now, that creates a barrier for that person to seek that outpatient treatment. And this is, we don't know how many people are out there that are coming out of the state hospital that have these high deductibles. We just don't know. But it's conceivable they exist. And so this is kind of a case where it's penny wise, pound foolish to do the third party liability and deny those services when if they don't receive those services, they could decompensate and back up in the state hospital on the state dime. So we're just asking for a year to kind of study the issue and make an informed recommendation back to this committee.
Okay. Questions for the Department of Health? Representative Hornock.
Thank you, Mr. Chairman. Why couldn't you study this issue without doing this?
Mr. Fuchs?
Mr. Chairman, so this system has been operated pretty much on a block grant basis for 50 years. So we just don't have the detailed information on people to determine, what is their insurance coverage. We don't really know that today. We don't know really what their income is. Everything is self-dec, like self-dec declared on income, for example. But with BHR, we are screening everybody rigorously for income, for residency, for social security number, for citizenship, for all these things. And so once BHR is implemented, we'll have much more reliable and detailed information on every single client we serve. And therefore, we can give you an informed recommendation of here's how many clients, have private insurance that are in these higher tiers, right? And here's how many people would affect. So here's our recommendation on how we implement third-party liability. And our recommendation may well be, do what Medicaid does and deny the claims. And because it's a minimal impact, there's not much TPL out there, so we don't want to build a big administrative infrastructure to handle this. That could be our recommendation ultimately, but we just don't know. We don't have the data to be able to substantiate that recommendation at this time.
Go ahead, follow up, Representative Hornock.
Mr. Chairman, so once behavioral health redesign is implemented this year, you will be able to collect this data that you currently don't have, even if we don't pass this bill, correct?
Mr. Chairman, Representative Hornock, that's correct. We will collect the data, but we will also deny those claims. So it will affect people's benefits to some degree, whether this section would pause that and let us collect the information and report back without denying the claims. It's a policy choice for you all at the end of the day.
And so, as I read this definition, tell me if I'm wrong. What we're doing is expanding the definition of indigent general access clients to just mean somebody below 200% of the federal poverty line. It doesn't deal with anything else. We're just expanding that definition so that anybody under that 200% of the federal poverty line is considered indigent general access clients. Thanks. Right.
Mr. Chairman, Representative Hornock is correct.
And well, perhaps I'll ask some other people what that means if this doesn't pass. Some other people, I'm sure in the audience, would kind of give a better idea, but you're welcome to if you'd like, Mr. Fuchs.
Mr. Chairman, I just want to take the opportunity to answer Representative Penn's question on what the dollar figure is. So the current poverty line is $15,000 ballpark. So for a single person, and it scales with the number of people in your household. So 200% of poverty for a single person was $30,000. If you have a family of four, it would be $60,000. Those are just some round numbers. And of course, it scales from, one being single to a family of four to up to 8 people, and it scales accordingly. But those are just some ballpark numbers for you.
Other questions for Health? Representative Hornock?
Mr. Chairman, so you're seeking to understand, collect data to find savings. Explain that savings. What would we save if we're paying for services, paying more for services? How do you explain how we would save money in the end?
Go ahead, Mr. Fuchs, a bit broader than this, but in general.
Mr. Chairman, Representative Hornock, so I would just, generally speaking, Medicaid does save money on third-party liability by denying those claims. So Medicaid, if we didn't have that information, right, with that link with the insurance company, we would pay that benefit, that claim for that member. And that's an expenditure. And if we deny the claim, it's not an expenditure. So there are real savings on the Medicaid side. The question is, on this specific general fund program, what is the policy for third-party liability is an area which we just don't have a good recommendation for you all. And because we don't have the data. So if we study this for a year, we can come back in 2025 and give you a recommendation and saying, we estimate there is X million dollars of potential savings to do the general fund through third-party liability recoveries. And here's how we recommend recovering it. But I don't know what X is at this point. It could be very small, and in which case building a big, all the systems to try to do this is not really the juice isn't worth the squeeze. That's our main concern is how much recovery is out there, and we just don't know.
Representative Ward, did you have a question, or did that cover it? Okay. Other questions? Representative Penn?
Thank you, Mr. Chairman. You mentioned earlier, you were saying the differences between BHR and how we are currently doing it or were previously doing it. You said we're screening for all these things, one of which is citizenship. Have we not been screening for citizenship, and what does that mean, citizenship?
Go ahead, Mr. Fuchs.
Mr. Chairman, Representative Penn, I should be more clear. It should be citizenship or legal residency. So Medicaid, there are basic Medicaid requirements. And because we are screening everybody and through the same system, it will automatically check. People will have to provide proof of citizenship and residency, as well as a social security number. And so previously that was not done. And we didn't have a policy to specifically exclude the people that may not have been citizens. But that's a change under behavioral health redesign that's being implemented.
Follow up?
Just one more, Mr. Chairman, thank you. So just tell me if I'm in the wrong direction here, but just to clarify, so you mentioned that this just gives us an extra year to study so we can gather the information that we currently do not have as to what numbers we're dealing with here. This does, though, change the current definition, which does require that we bill health insurance, so that is allowed. And that isn't a one-year change, it's just the 1 year is that you come back in a year and report to committee. Is that correct?
Mr. Chairman, Representative Penn, I think that's accurate. The 1 year timeline is specifically for the third-party liability recoveries, suspending that. But I want to point out that even if, say, someone is covered by private insurance or Medicaid under this indigent general access clients, if we decide to implement third-party liability recoveries, we will deny those claims. It's just going to be for benefits that the insurance may not cover. So for example, the substance use residential treatment, then we'll pay the claim because we know that Medicaid doesn't cover it. But for any other pay source, even if they're eligible under Romanet 19 here, we will, if directed, we will implement third-party liability systems to recover or avoid those costs.
Is it fair to say that this language keeps the status quo for another year? Part of this new definition was the behavioral health redesign. And then after we kicked that off, we said, well, we don't actually know the numbers and whether we're going to get enough money back to justify the costs. So by deleting the language in the bill and adding this kind of 2-year window, we're actually keeping the status quo of what we've had since '74 or something.
Mr. Chairman, that's accurate.
Okay. Other questions? Mike. Seeing no other questions right now, but don't go too far, I'm guessing. Same order of operations. Ms. Somerville, you want to be next? Go ahead, Andy.
Thank you, Mr. Chairman, members of the committee. So WAMSAC stands in support of this bill, and we're hoping that we can get it passed out of committee this morning. So as was described, this is essentially another 2-year window to study the data and bring some information back to you. I want to provide a very specific example of one of the groups that we're concerned about if this bill does not pass, and that is our pregnant and parenting women group. So right now, the state contracts for, I believe, 25 parenting women or pregnant women beds. So these are residential beds that the state has asked us to maintain where somebody, a woman that is pregnant or has recently had a child, and they can actually bring a kiddo up to, I think, age 3 or even 4 into the program with them that has a severe substance use disorder that requires residential treatment. Most of the time, especially on the pregnant and now on the 12 months postpartum side, those women are all going to be on Medicaid. Medicaid does not cover any type of residential substance use treatment. If this bill does not pass, we will no longer be able to provide those programs. It will be very difficult in our research and trying to find alternative solutions to find another funding source that would allow those residential programs to continue. So essentially, we could provide to those women the services that were available on Medicaid only, and we wouldn't be able to do anything else. While this bill doesn't have any financial impact to the state, we're utilizing, again, the capped amount of money within the community mental health system. I do want to talk about the costs that the state may face in terms of unintended consequences, maybe if this bill is not passed with this population that'll be affected. So whether you're talking about somebody with Medicaid who can't access residential services, or you're talking about somebody with private insurance that can't access case management services, or it's still pretty common to see private insurance plans where visits are capped and other services are excluded. Currently, the state hospital cost is, I believe, more than $1,300 a day, per day. So obviously that is a cost we think is best avoided, as well as keeping people in the communities. The other population, when you're talking about groups that may be involved with DFS, there's a cost there. The one that's really hard to quantify is criminal justice. So if somebody is not receiving the services, it is not uncommon for them to boomerang back through the law enforcement system. They can decompensate, they can have interactions with law enforcement, end up in jails and going back through the system for a variety of reasons. Those costs are countywide, they're statewide. And with behavioral health redesign, what the Community Mental Health Center has been asked to do is avoid those costs, is to try to wrap our arms around these folks and try to keep them out of the state systems, whether it's a county jail or the Department of Corrections or the state hospital, or an adolescent going to a psychiatric residential treatment facility. And so that's really what we're trying to do. This system, in terms of being able to, let me back up. I think that the question for us here is the idea that the state needs to be the payer of the last resort. That is not a new concept. That is the way the community mental health centers have operated for decades. So if somebody has Medicaid, we bill any services that that client needs to Medicaid first, and we only bill the state contract for services that Medicaid doesn't cover. What this bill seeks to do is not only to maintain that piece, but allow us to come back to you with additional data. I want to just close my comments by saying that this isn't, I think there's been a lot of misinformation about what this bill is and what it isn't. It's not a large impact to the system. We're not talking about this particular bill affecting tens of thousands of people. While we don't have the exact numbers, the best guess that our community mental health centers could provide me is maybe a couple thousand in terms of clients that are in this particular situation where they're on Medicaid or private insurance that doesn't cover services that we need to utilize the behavioral health center contract for. And so, Mr. Chairman, I think I'm going to just stop there and see if there are any questions from the committee.
Would it be fair to say a large number of the other insurance people would be TRICARE outside of Medicaid?
Mr. Chairman, that is correct.
Other questions, committee, for WAMSAC? And I know we can kind of go into what ifs, but with the plans of safe care we put in legislation, without this, I'm not sure what happens if there's nowhere to go for, mothers who have substance abuse issues and we're trying to figure out how to get them some treatment. I would assume they would, the anticipation last year was, in many cases, they would go to their local behavioral health center. Would that be correct?
Mr. Chairman, that is correct. The plans of safe care legislation that was passed would essentially, in terms of being able to provide the care for these women and mothers, we wouldn't be able to support that. While there are a few small private entities that try to do some substance use residential, the community mental health centers are the only programs in the entire state that provide parenting or pregnant women beds and that program. And if we do not have the ability to work within that system, it is conceivable that those beds would no longer exist.
Questions for WAMSAC? Seeing none. Other people wish to testify on this bill? Everyone's shaking their head no. Just here for the fun of labor health on a Wednesday morning. All right, no one online? Any other comments on Senate File 115? It's fun to hang out with us, isn't it? All right, we'll close public comment, and Representative O'Hearn is going to move Senate File 115, second by Representative Chadwick. Any amendments on the bill? No amendments on this? Okay. Any discussion, committee? Seeing no discussion, oh, Representative Hornock.
So we have looked at this already this legislative session, and I'll kind of have the same comments. This doesn't specifically push a Medicaid expansion, but it certainly, in a subtle way, collects the data, in my opinion, so that it can be. And that's because Medicaid expansion requires three things. It requires income level. It requires Medicaid to be the payer of last resort, which then means you need the third-party billing portion of it, and Medicaid is said to be a savings for us because then the feds will essentially pay 90% of Medicaid services. I find those three things in this bill, which is why I'm really nervous about this type of thing. The legislature for several years has been pushing back against the Medicaid expansion. In my opinion, this bill will give a lot of information to show what could be termed savings for the expansion of Medicaid. And by savings, I mean it's just because we're going to let the feds pay 90%, which generally is still taxpayer dollars. It's still our money. And the feds, I don't think can afford it. So anyway, it seems to me like by doing what's in this bill, it's really not going to add too much to the behavioral health redesign already. They can collect this data starting whatever June or July, whenever those services come online. So they'll get most of the data they're looking for already once that system starts. This, in my opinion, sort of is directing the system in a way that I don't really think personally it should go. So, I'm gonna not be in favor of this bill for those reasons.
Other comments, discussion? Question. Seeing none, and question being called, Barb, if you'd call the roll on Senate File 115.
Representative Chadwick?
Aye.
Representative Clouston?
Aye.
Representative Hornock?
No.
Representative O'Hearn?
Aye.
Representative Penn?
No.
Representative Trujillo,
Aye.
Representative Ward. No. Vice Chairman Yin. Chairman Swanitzer.
All right.
6 aye, 3 no.
And I assume I'll probably cover that as well with the good Vice Chairman of Approps on the floor. I mean, I have the sense that you may speak on Senate File 115 on the floor, Riffin and Hornock, but no, I think I'll go ahead and take that one. Committee, we do have 2 bills scheduled for Friday. One is on a nursing home administrator repeal, and then I can't remember the other off the top of my head, but they're the 2 that are assigned to this committee. We might get a couple more this morning, so we'll wait and see what else gets assigned and then schedule appropriately. We do have our joint meeting with the Senate a week from today, and interim topic requests are due by Monday, from what I remember. So is they Friday? Friday, so you might have some people seeking you out to put your name on some of the interim topics to come to us. So last year we had like 38 different topics. I expect we'll have that many again. Representative Clouston? I will send LSO to find you to, it depends if you want your LSO staff working past 5 on Friday. So 4 would be great if you know, but there are, I think, going to be available to be submitted online as well up until they shut it off on Friday night. So I bet it's going to be midnight, and then LSO will work over the weekend to get us a list on that Monday, from what I understand.
Mr. Chairman.
Yep.
The calendar, on the online calendar, it does have 4 PM as the form deadline.
4 p.m. Anything else come before the committee? If not, we'll maybe try for 8:30 again on Friday. This is working out for us well. We are adjourned for today.